Hello. In this case, we'll be talking about maxillary and mandibular veneers and tooth-colored crowns. We'll be veneering the 10 maxillary anterior teeth and veneering and crowning the 10 mandibular anterior teeth. In this first episode, I'll be veneering the mandibular 6 anterior teeth and crowning with tooth-colored crowns the mandibular bicuspid teeth. This is before and after. The incisal plane, topical anesthesia, local anesthesia for the mandible. You can look up that link in the library of dentistrymasterclasses.com. I always start with my morning case. Normally I see one case every morning from 8 in the morning until about 1 in the afternoon. So I've always got an outline of approximately where I want to be by a certain time so you don't get lost and get behind, and this way I know if we're about on the time schedule. It's not rigid, it's just general. So anytime I can use a rubber dam, I like to, but I like to use this technique that I started using years ago that's very easy. Studies show that most dentists don't use a rubber dam just because it's too much trouble to put on and floss between the teeth. And then when you prep a tooth for a crown or any type of interproximal restoration, you cut the rubber dam. So this is just one cut, stretched tight. You can see there's nothing between the teeth, and it accomplishes 99% of what the conventional rubber dam technique accomplishes, which is to keep the lips and the tongue out of the operating field. If there are any pieces of old crown, or also water keeps 99% of the water out of the mouth and the pieces of old fillings or old crowns out of the mouth. So plus it makes your assistant's job much easier. When I'm placing tooth-colored restorations on mandibular teeth, I try not to place a crown on the mandibular anterior teeth. Also try not to place a crown on the maxillary anterior teeth if we don't have to, because those are smaller teeth. The veneer preparation is much more conservative. You're not preparing the palatal or the lingual side of the tooth. But in the mandible, I place full crowns on the bicuspid teeth and then veneers on the mandibular anterior teeth. In the maxillary teeth, we can place veneers on all 10 of the teeth from bicuspid to bicuspid. I'm reducing the occlusal surface of the bicuspid teeth approximately 2 millimeters. And this 330 carbide burr is 2 millimeters from here to here. So that's just my depth cut, so I know how much to reduce the tooth with my occlusal reduction burr. I also like to cut into the interproximal with the 330 carbide burr and then follow with a flame-shaped diamond or a mosquito diamond. Open the contact. This is just an occlusal reduction burr, so I'm not having to think about how much occlusal reduction I need to prep, because I've got the depth cuts and I just prep to the bottom of the depth cut. This is a coarse barrel diamond, and I'm reducing circumferentially around the teeth about 1 millimeter. If possible, now if there's a big super bulge on the tooth, on the palate, the lingual, or the facial, then I'm not going to reduce the entire surface of the tooth to reduce a full 1.5 millimeters in the gingival 1/4 of the tooth. I may just have a lot less because I don't want to cut that much tooth structure away. See, normally there's a super bulge on the facial of the bicuspid, so I'm not going to reduce the entire super bulge, which means I'm not going to be prepping into the tooth in the gingival 1/4 more than about 1/2 millimeter. This is a mosquito diamond to open the contact. I want to prep past the contact gingivally. I'd like to keep this supragingival if I could interproximally, but I want to break the contact. This is a flame-shaped diamond. And And this is a small chamfer fine diamond. And I'm using that to place the margin. I want to place the margin about a 1/2 millimeter subgingivally. Now, if the tooth is not in the aesthetic zone, meaning any posterior tooth, normally the gingival 1/4 to 1/2 of the tooth is not displayed when the patient smiles or talks, you don't have to worry too much about getting the margin subgingival. Whereas in the maxillary anterior teeth, you've got to think about prepping subgingivally. So I want all those margins in the maxillary anterior teeth back to probably the first molar to be prepped 1/2 millimeter to 1 millimeter subgingivally, because the maxillary anterior teeth and the bicuspid teeth and sometimes the first molar teeth are in the aesthetic zone, meaning those teeth are displayed when the patient's talking and smiling. The mandibular anterior teeth and bicuspids are normally not in the aesthetic zone, so you don't have to be concerned with the margin being placed subgingivally, especially if it requires reducing a lot of tooth structure on the facial or even the lingual because of a superbulge. So I'm looking at the tooth from the facial to be sure I've got approximately 2 millimeters of occlusal reduction. And this is the other side, doing the same thing, making my depth cuts and interproximal cuts initially with the 330 carbide burr. And again, because that's 2 millimeters from here to here, that's an ideal depth cut. Now, a lot of people say, well, you only need to reduce the occlusal 1.5 millimeters. I like to reduce it 2 millimeters approximately, because you know the technician has got plenty of room and it doesn't affect the tooth. I like the depth cuts because it's kind of like placing a line on your golf ball for putting. If you line up the line with where you want to putt the ball, you don't have to think about the line anymore. All you have to think about is the speed. And so this is the same thing with the depth cuts. You don't have to constantly be checking to see how much occlusal reduction you have. You know, you just prep to the bottom of the depth cuts, and that's going to be the correct occlusal reduction. This is a flame-shaped diamond, and I'll use that, and if the contacts are tight, even below the contact, the primary contact point, I'll use the mosquito diamond just to break the contact, and sometimes that'll take the prep slightly subgingival in the interproximal area. I'd rather not go more than a 1/2 millimeter subgingival in the interproximal area. You can see how we've got a super bulge here. So what I'm talking about with this prep, you don't want to make a two-plane prep because the crown has to be able to draw. So a lot of times if the tooth is not in the aesthetic zone and there's a pretty good sized super bulge, or if there's dentin exposed or cementum in the gingival 1/3 or 1/2 of the tooth, I'll keep the prep in enamel and only prep to maybe halfway gingival into the superbulge. So I don't prep into the dentin or the cementum, because that can create hypersensitivity. So anytime I can leave a prep in enamel, I'd rather do that. And I'm doing that here. See, this is all in enamel. This is cementum or dentin below this prep. So it's not in the aesthetic zone, so have the patient smile preoperatively and take photographs of that and see where the aesthetic zone is. What teeth are displayed when the patient is speaking, laughing, or smiling. And if the mandibular teeth are not displayed, you don't have to prep all the way to the gingival line. So these are subgingival preps on the bicuspid. Round all the line angles, checking the occlusal reduction. That's approximately 2 millimeters. You can see here's the margin and there's the margin. So they're not subgingival, because this might create hypersensitivity if I reduced all that tooth structure, and especially in the cementum or the dentin, in the gingival 1/3 of the tooth. You don't want to create a hypersensitive tooth. So rounding those line angles, and you can see here's the margin and there's the margin. Now I'm prepping the teeth for veneers. This is a coarse barrel diamond, and I want to prep the teeth for veneers approximately. First, I'm cutting them back into the correct arch alignment. If you've got a tooth that's facial verted, you want to cut the teeth back into the correct arch alignment. Then the veneer preparation begins. So first cut them back into the arch alignment, where you look at the teeth from the incisal surface, and the center of the teeth should be in the same arch alignment. Then once you've accomplished that, then you can begin the reduction for the veneer, which is about 1/2 millimeter from the alignment when the teeth are in the correct arch alignment. That's one of the nice things about veneers. You don't have to have much tooth reduction on the facial. We are going to include the interproximal surfaces and the incisal surface, but you've got lots of good tooth structure remaining after a veneer prep, even though you're including the interproximal surfaces. Then I'm cutting between the teeth interproximally, and I like this burr because it has a straight side. You know, a flame-shaped diamond has a curve, and so I want to cut straight between the teeth, and I like this particular burr for that. You've just got to be sure that these preps, the interproximal preps and the facial prep, draw. So the provisionals will draw and the veneer will seat. Now if we've got this part of the tooth contacting, the gingival 1/4 of the teeth are contacting, then we'll come back with a mosquito diamond and break that contact. I'm not wanting to go very far subgingivally, maybe 1/2 millimeter, but that's not in the aesthetic zone, so all I'm doing is wanting to break that contact, and mosquito diamond is ideal for that. You can see this part is still contacting, so we'll come back with a mosquito diamond and break that contact. The mosquito diamond also has straight sides, so you know everything. See, there's a mosquito diamond, so you know the prep will draw. Then I'm going to come back with a flame-shaped diamond once I've broken the interproximal contacts. And I'm not trying to prep deeply into the tooth, about 1/2 millimeter. And then remember, you've only got about 3/10 millimeter of enamel in the gingival 1/4. So you'd rather keep the prep in enamel. So I'm just going to sort of roughen the prep in the gingival 1/4. I'm not going to go deep into the tooth. And be sure your technician knows that even though you're not going to see maybe a distinct preparation margin, that he or she knows that the preparation is at the gingival line or about 1/2 millimeter subgingival on the facial when they're fabricating the restorations. Because you don't want to end up with a restoration that's way up here on the tooth, but there's not going to be a deep preparation margin on the facial surface of the tooth, because the enamel is so thin in a tooth, like I said, only about 3/10 of a millimeter in the gingival 1/4, that you don't want to prep into the dentin if you can help it. The bond strength to enamel is significantly greater than bond strength to dentin. The incisal preparation for veneers is flat. You don't want to taco the preparation. You don't want to roll it over to the lingual or even the palatal on the maxillary teeth. So I want this to be flat, and I'm going to round the line angle interproximally, incisally, and facially incisally. But the line angle incisal lingually is 90 degrees. Don't round the line angle on the lingual. I'm going to check the occlusal reduction, the incisal reduction. I'm going to round the facial incisal line angle and the interproximal incisal line angle. But again, I'm not rounding the incisal lingual line angle. You want that one to be 90 degrees. That creates the strongest restoration. So I'm constantly checking the reduction because I want about 1.5 millimeters of reduction between the mandibular teeth that are being prepared for veneers and the maxillary teeth, the palatal surface of the maxillary teeth. Again, checking the reduction to be sure I've got room for my veneers, and you want about 1.5 millimeters or 2 clearance between the prepared mandibular teeth and the palatal surface of the maxillary anterior teeth. You can either stay with the flame-shaped diamond, or you can go with a small chamfer diamond for the margin. But just right at the gum line or just slightly subgingival. And this is the reduction. I've got about 1.5 millimeters clearance. You can see how these were super gingival margins on the bicuspids. Here's the margin. I don't want to prep onto the cementum or the dentin here. And this one, this margin is right there. I'm not worried about going subgingival. These are just slightly subgingival from cuspid to cuspid for the veneers. This is the other side. See, here's the margin, super gingival, and this one's the same way, about right here. This is a wax up. You can look at the video on how we fabricate provisional restorations and why we wax them up on a stone model to make the provisional veneer material a little bit thicker, because you're going to fabricate the matrix for the provisionals on the waxed up model. If you fabricate the matrix on the pre-op model, you're only reducing the teeth for veneers about 0.5 millimeter, which means the provisional material is only about 0.5 millimeter thick, and that's not thick enough to work it with. It's like working with toilet paper. So I have those waxed up so that the provisionals are going to be, matrix is going to be fabricated from the waxed up veneers, and I want the provisional material to be at least 1 millimeter thick, and that's thick enough you can work with. So this is fabricated on the waxed up model, a polyvinyl siloxane matrix. You can watch that video in the library of dentistrymasterclasses.com. I'm going to try it in, see how you mark the midline. So we've got full crowns on the bicuspids, veneers on cuspid to cuspid. Be sure the tip of the bisacrylate syringe is rubbing the bottom of the matrix so it breaks the surface tension so you don't get bubbles. Then wet the teeth and place the matrix with the bisacrylate. Going to place cord around the bicuspids. We're not going to place cord on the mandibular anterior teeth that have been prepped for veneers. That tissue is too friable, it's too fragile. And so we're going to place some cord interproximally around the crown preps on the bicuspids. We don't have to place it on the facial because those margins are super gingival. This is blockout material. We're going to place that interproximally around the teeth that have not been prepped for crowns or veneers. It's the custom tray. You always want to use a custom tray with polyvinyl siloxane or polyether. I like polyether because polyether is hydrophilic. It likes water, and we're working in a wet environment. So I'm squirting the wash material on the body material, which has been squirted into the custom tray. You can see how to make those in the videos in the library of dentistrymasterclasses.com. See how crisp and clean those margins are? Here are the provisional crowns. Now this is warm water, and I'm going to chase the polyether impression with a reversible hydrocolloid impression. Reversible hydrocolloid is very accurate. Most of you don't know what that is, but it's a very accurate impression material. You have to have trays, special trays, and a hose of water that goes through the tray. It sets up when it's cooled. When it's heated in not a liquid phase, but kind of like jello, so you can see how crisp and clean those margins are. Anytime I prep teeth or a tooth for crown or veneers, I take either 2 reversible hydrocolloid impressions or a polyether with custom tray and a reversible hydrocolloid impression. If there are 2 or less teeth being prepped, I'll take 2 reversible hydrocolloid impressions. If there are more than 2 teeth being prepped, I'll take a polyether with custom tray and a reversible hydrocolloid impression. The reason I take 2 is because if there was anything I missed on the impression, there was a void or a blib or something, or I would have a backup. And also I can use the reversible hydrocolloid impression for a solid model to perfect the interproximal contacts. They're trying the provisionals on. If I've got a provisional 8 or 10 teeth, I usually like to trim it and adjust it in 3 parts. The bicuspids, the anterior teeth, maybe the bicuspids and the cuspid, and then the 4 anterior teeth. You always want to cut it up interproximally so you don't strangulate the papilla. This is a 2-sided diamond disc. Then I'm going to take a face bow. You can watch that video. This is very important because it orients the case on the articulator the same way the teeth are oriented in the mouth. Remember, you want this bar to be parallel to a line drawn between the pupils. The bite wax could be however the teeth are oriented, but this should always be parallel to a line drawn between the pupils. Many different types of articulators. I've always used a Hanau, and it's just real simple. If they're too complicated, people won't use the articulator. Then with mandibular, anterior teeth, and bicuspids, you can take a bite record because there's space between the prepped teeth and the opposing teeth. I'm going to continue adjusting the provisionals. You can see I've cut these temporaries up interproximally so the papilla can breathe. If you don't, and the provisional is pressing on the papilla, you can strangulate it. So I'm making some retention cuts in the 2 sides of the provisionals where I've broken the provisionals, so I'm seating them in 3 pieces. I'm going to wipe the teeth with Tublicid Red, just a cleaner and a disinfectant and a desensitizer, and put some Vaseline on the provisionals, not in the area where I've broken the provisionals. I'm going to put Olympia cement. So I'm going to place the cement first, then I'm placing just adhesive in the veneers provisionals. And then push those to place. And I'm doing the same thing, adhesive and then Olympia cement in the provisionals for crowns. And then I'm going to lute them together with flowable composite. Use this ball burnisher to wipe that area. Then I'm going to use a little more flowable. I'm blowing off. You saw me blow off the excess adhesive onto a 2x2. Then I've cured the adhesive. I'm going to cure the adhesive. When I cure the adhesive, I'm going to cure between each provisional about 40 seconds. You don't want to let the Olympia provisional cement set hard, but you do want it hard enough that it'll peel off and not wipe off. That's true with any cement. Permanent cement, veneer luting composite, you want to remove it in the initial set phase. You don't want to wipe it off. You want to chip it off or polish it off. Adjust the occlusion, just perfecting the margins. Don't touch the tooth. Just use this flame-shaped diamond to perfect the margins and adjust the occlusion. So all the provisionals are connected. The reason they're connected is you don't want the teeth to move while the teeth are in provisionals. I'm doing final adjustment with these gray Shofu rubber wheels. Pop the floss through and then pull it to the side, put a knot in the floss. Now this is waxed floss. You don't want to pull it back up or you might pull the provisional off. Move it to the side. So this is before and after. That's where we're heading. So you can see these margins are supragingival on the bicuspids. These are the final restorations. That's dentistrymasterclasses.com. These techniques work and they work every time. Hello, this is the second episode in this series on veneers on the maxillary anterior 10 teeth and veneers and crowns on the mandibular anterior and bicuspid 10 teeth. In the first episode, I prepped the mandibular anterior and bicuspid 10 teeth. In this episode, I'm going to be seating those restorations. These are lithium disilicate Emax restorations. This is before and after. So these are the provisionals on the mandibular anterior 10 teeth. We've got veneers from cuspid to cuspid and full crowns on the first and second mandibular bicuspids. We've not done anything to her maxillary anterior teeth yet. Local anesthesia. You can watch that video on how to give profound and painless local anesthesia. So when we're checking the restorations, they're fabricated on a die model, but then the interproximal contacts are perfected on a stone model. You can watch that length. So this is the stone model, and this is the die model. I want my technician to give me this little piece in each case to know that he's treated the lithium disilicate. I said, I trust you. I know you probably did it, but just for peace of mind, I want you to put this little piece in there with a check on it so I know it's been done. We're cutting between the provisionals with this mosquito diamond. You just put a 2x2 in the mouth and just torque interproximally with an elevator. Remember, those were just seated with adhesive, not primer, and the teeth weren't etched. They were just seated with adhesive, and the bicuspid crowns provisionals were seated with Olympia provisional cement. So I'm removing the provisionals and I'm polishing with pumice and water. There's no hydrogen peroxide because the peroxide, as you know, might affect the bond strength. So we're just polishing with pumice and water on a Profi cup, then rinsing. I'm not worried about bleeding right here. I've got a 2x2 in the mouth, and I'm going to wipe the teeth with isopropyl alcohol just to clean anything off that the pumice and water didn't get. This red rope wax and cotton tip applicator is an excellent carrier. I'm going to try everything in. Remember, we perfected the interproximal contacts on the solid model. Now, many times I'll cement the veneers and the crowns at the same time. In this case, I'm cementing the veneers in one phase and then coming back and seating the crowns. Wipe them with isopropyl alcohol. They've been treated already as you treat lithium disilicate or Emax. You can watch the video on how to treat the crown or veneer before seating. Put a little Vaseline on the interproximal contacts after you wipe the tooth side of the veneer and the crown with isopropyl alcohol. Just a little touch of Vaseline just keeps the cement from setting or being difficult to remove interproximally. You don't have to treat them again, just blow it dry. You don't have to rinse the isopropyl alcohol off, just blow it dry, and that's fine. Line them up, then you're going to etch with 38% phosphoric acid. Now, if there's no dentin exposed, you can etch each tooth for a minute or even more if you wanted to, if it's just enamel. So I'm going to time it. I generally leave it on for a minute. Now, you notice I was rinsing that off with this water bottle of water. Once I've etched them, you don't want to rinse it again with your air water syringe. If you do, you might elicit bleeding. So rinse it off with this water bottle with a pretty big opening with cold water in the water bottle. I'm placing the primer adhesive on the veneer on the tooth side and I'm blowing it off. You don't want excess primer adhesive on the veneer because acetone is the carrier and you want to blow that acetone off or the acetone can negatively affect the bond strength if you just blob it on there and leave a lot of excess. So blow it off until nothing wiggles. And I like to blow from this direction into the incisal of the veneer because it ensures that you get anything out that may have pooled in the incisal part. And I'm going to do all these at the same time. Now remember, before I've done this, we've turned off the light in the operatory, the overhead lights. And I've taken the light on the chair and turned it down toward the patient's feet. So there's just a very light glow on their face because you don't want the ambient light to set up the primer adhesive. So there's no light in the room, there's just the light on the operatory chair that's turned down toward the patient's feet and just a little glow. I don't desiccate the teeth, I've just blotted them dry and placing the primer adhesive on the teeth to be veneered, putting a large amount on there, and then I'm going to blow it off into a 2x2 and shielding the bicuspid teeth from the veneered teeth so I don't get that primer adhesive on the teeth that are going to receive crowns. I'm squirting this Rely X made by 3M veneer luting composite onto each veneer and seating them all at one time. Most of the time I seat the veneers and then seat the crowns before I initially cure the veneers. In this case, I'm just seating the veneers. I'm going back and just place my thumb on the incisal and using a cotton tip applicator on the facial and pushing gently but firmly. And then I'm going to wipe off some of the excess on the lingual to be sure the margins are seated and the incisal edge is in the correct arch alignment. I'm going to floss between each one with wax floss. See, I'm pulling it to the lingual. For sure, don't pull it to the facial or you'll pull the veneer off. Then just quickly cure those. It's amazing how fast they set up, but that's like boop, 1001 on the facial, stop. Boop, 1001 on the lingual, stop. You don't want to set them completely. You just want the luting composite to be about like crunchy snow so it will peel off and not wipe off. If it wipes off, you'll get some suck back in the micro gap between the veneer and the tooth, and bacteria can get in that micro gap and lead to tooth sensitivity, inflammation, redness, and possibly even decay. So you want that excess to peel off. That's with a veneer or a crown. But they're not set completely. It's just enough to peel it off. If you set it completely, you'd have to cut it off, which I'll polish here in a minute, but I just want to peel this off and then floss. And pull the floss, again, this is waxed floss, and pull it to the lingual. If you have any trouble flossing, you can use this floss shredder with the wax floss, again pulling to the lingual. Now we're going to seat the crowns. I haven't cured the veneers completely yet. It's like a military operation when you're seating all these. You really want an assistant that knows what she's doing. You may have just a little adjustment. If anything is tight, you can use this occlude to find out where the tight spot is, especially if you're cementing them, the crowns, separately from the veneers. You may have a little adjustment. Then we're going to cure the veneers, and I like to cure them 60 seconds on both sides, 60 seconds on the facial and 60 seconds on the lingual per veneer. That's overcure, but you can't overcure composite. You can undercure it. I want to be sure it's completely cured. Then I'm removing the excess luting composite from the veneers with this large, fine chamfer diamond. I'm coming back with this 12 fluted carbide burr and just very lightly polishing the margins to be sure every little bit of excess composite is removed. This is why you don't want to seat veneers individually, because if you do, you're going to have some bleeding and you're going to have to deal with that with each veneer. And I'm using that Shofu rubber wheel when I did a tiny little bit of adjustment on the interproximal of the crowns. I wanted to try those in one more time just to be sure they were perfect. And so I have to come back and isopropyl alcohol them again. It's a lot easier to try them in and get it perfect before you cement them than to have to cut one off because it doesn't fit perfectly. I'm going to wipe those teeth with Tublicid Red before cementation of the crowns. This is Unisim Crown and Bridge cement. When you're trying them in, you want to be sure you know the order of trying them in, because sometimes one should be seated before the other, depending on the angulation of the prep tooth, so they seat properly. Then on that left side, I seated the second bicuspid and then the first bicuspid. On the right side, I'm seating the first bicuspid and then the second bicuspid. You don't want to have a seating problem, though, with the cement in the crown. You want to find out if you've got a tight interproximal contact for any reason before you seat the crown. That's why I like plenty of time with the preps and the seating. I'll schedule a morning to seat the veneers and the crowns just to know I've got plenty of time to deal with whatever I need to deal with. Most of the time it won't take as long as I think it will, but I'd rather have more time than less time. Or I'll say most time it'll take less time than I gave time for, just to be sure I had time to do whatever I needed to do. You don't want to be rushed in these involved cases. So again, you want to remove the excess cement from the crown when it's in the initial set stage. If you let it set completely, you may have to polish it off. So I want to remove it when it's initially set, and it'll peel off, not wipe off. Don't ever want to remove cement in the flowable stage.
You like Brianna better.
Shut up. Doing drugs. When you were flossing right there? Or not flossing, when you were scaling.
So I'm just polishing those margins to be sure you can see how this is supragingival here. It's not in the aesthetic zone, but if I prepped all the way down to here, I'd probably have a hypersensitive tooth. If you prep onto cementum, you may create a hypersensitive tooth that might require endodontics. So you want to know if that's going to potentially happen so you can discuss it with the patient before you prep the teeth. In the mandibular, you don't have to prep subgingivally because those teeth are not in the aesthetic zone. You can keep the preps in enamel. I'm going to check the occlusion, just fine tune the margins, be sure everything is nice and smooth. So I'm using a fine chamfer diamond or flame-shaped diamond on the lingual of the anterior teeth that were veneered. And I'm using this 12-fluted carbide burr on the facial of the veneers and the crowns, and the lingual of the crowns on the bicuspid teeth. Then once I've got the margins like I want them, they're nice and smooth, I'm going to come back with this Shofu rubber wheel and polish from the veneer to the tooth and just put a fine, fine finish. See, this is polishing in this direction from the veneer to the tooth. So that's when the patient, as they leave the office, this is before and after. That's dentistrymasterclasses.com. These techniques work, and they work every time. Hello, this is the third episode in a very interesting aesthetic restorative case. We're restoring the maxillary and mandibular anterior teeth and bicuspids. Why include the bicuspids? If you're changing the shade, if you're lightening the shade of someone's teeth, there are few things to me that look more artificial and worse than 6 maxillary anterior teeth restored to a lighter shade. Because if someone's looking at them from the side, the dark posterior teeth are still present. And so anytime I'm changing the shade, I want to restore 8 to 10 maxillary anterior teeth and usually 8 to 10 mandibular anterior teeth and bicuspids. So when you're doing the preoperative comprehensive exam, be sure you take photographs of the patient smiling from the front and from the side and see how many teeth are displayed when they smile. That if you're lightening the shade, it looks very artificial if you don't include all the teeth that are displayed when the patient is smiling. So watch that video on the new patient interview, exam, and consultation appointment, and you might want to do it that way, because that's what I've found through the years is the best way to do a comprehensive exam and consultation. So this episode is the third one. Like I said, it's preparing the maxillary anterior teeth for veneers and crowns. And so we'll be including 10 teeth, so we'll be extending the preparation to the maxillary second bicuspids. Now, how do I decide on the upper teeth, the maxillary teeth, if I'm doing a veneer or a crown on the bicuspids? If there's a large restoration, interproximal restoration in the teeth, I'm going to do a full crown. I'm not a fan of large interproximal composite fillings because over time they normally break down. The coefficient of thermal expansion of a filling, either silver or composite, is about 75 and a tooth is 11. So when the patient drinks or eats hot and cold, that filling is going like this and the tooth's going like this, so they pull away from the teeth and leak over time. The other thing, if you've got a large interproximal composite or silver filling in a tooth, there's nothing holding the sides of the teeth together, and those teeth are prone to split. So if it has a large filling or an old crown that's not the right shade, I'm going to either replace the old crown or restore the tooth with a large filling with a crown. Then the other teeth, the maxillary anterior teeth, will receive veneers. I'd always rather restore an anterior tooth with a veneer than a crown, because you're preserving tooth structure. With a veneer, you're only removing about a 0.5 millimeter of tooth structure. 99% of the time, you're still in enamel, and the tooth is as strong as it was before the restoration. With a crown, you're removing tooth structure circumferentially, and you're removing about 1.5 to 2 millimeters of tooth structure. So it actually makes the tooth a bit weaker, especially if the tooth has had endodontics. It's going to weaken the tooth. So if a maxillary anterior tooth has received endodontics, but you're not placing a bridge, I would prefer to place a veneer versus a full crown, because with the endo, you're removing tooth structure on the inner part of the tooth, and with the crown, you're removing tooth structure circumferentially around the tooth, and that combination reduces quite a bit of tooth structure. So if you can, if anterior tooth has had endodontics and you're restoring it for aesthetic reasons, I would prefer to place a veneer. Now, if the tooth has had endodontics and it's not dark and you're not veneering all the teeth, if it's not an aesthetic case, don't place a restoration on the tooth if it's an anterior tooth, maxillary or mandibular. So here we go, prepping maxillary teeth for veneers and crowns. Okay, this is before and after. These are the teeth restored, maxillary and mandibular anterior teeth. You can see we've got crowns on the bicuspid teeth. We've also restored this mandibular first molar tooth and that maxillary first molar tooth and this one up here. So we've restored back to the first molar on this would be the left side because it's in a mirror, and to the second molar, to the second molar on the left side and the first molar on the right side, you can see how these teeth, this bicuspid and this molar, have full crowns because of the size of the filling in the tooth. Now this bicuspid had just an occlusal composite and didn't have any cracks in the tooth, so it received a veneer. And then the anterior teeth have been veneered. And these are the mandibular teeth. You can see we've corrected some crowding with the veneers. Now if it's major crowding, the patient probably needs orthodontic treatment prior to veneering, but if it's minor crowding, you can usually correct that with veneers. And then we had some large fillings on the crown back here, and I always restore mandibular bicuspids with full crowns. I don't place veneers on the bicuspids because the stamp cusp, the buccal cusp, would be receiving all the pressure for one thing, and just the likelihood of fracture is greater. And when someone's looking at the patient's teeth in this direction, they can see that the lingual part of the bicuspids is darker than the facial part. So full crowns on the mandibular bicuspids, veneers on the mandibular incisor teeth, anterior and cuspids, and then veneers on the maxillary anterior teeth and bicuspids, unless there's a large interproximal composite or silver filling in the tooth. Then you'd place a crown on even the maxillary bicuspid teeth if it's an aesthetic case. Okay, so we've restored the mandibular teeth with veneers on the anterior teeth, crowns on the bicuspid teeth. You can see this is a supragingival margin on these two teeth. The reason for that is they're not in the aesthetic zone. You can't see the gingival half of the tooth when the patient smiles or when they're talking. And I'd rather not prep onto the cementum of the tooth or remove all of that suprabulge, just preserve the tooth structure. I've got a crown on my mandibular first molar, and it had a large suprabulge, and I had the dentist that restored that tooth leave the margin supragingiva, above the gingival tissue, as I've got a little bit of recession, and you'd rather not prep down onto the cementum if you don't have to, because it might make the tooth hypersensitive. Plus you've got to remove more tooth structure to get a 0.5 millimeter of reduction in this gingival third. So now we're going to prep the maxillary anterior teeth and bicuspids. You can see the abfraction over here, abfraction over here. Remember, that means the patient is I call it, they have good-hearted woman syndrome. It means they clench their teeth because they're working out not just their problems at night, but the whole world. And that's when you see that gingival recession and abfraction. We used to think that was from toothbrushing. Now we know that's the flex point when somebody clenches their teeth, like breaking a bobby pin or a paper clip. When you flex it like that, that's the flex point where they blow the enamel off the side of the tooth. So it's mandatory. Any of these veneer cases have a night guard, but in these cases, don't even restore the case unless they have a night guard. I've got a whole lecture series on photographs of veneered cases that have fractured the restorative material at the gum line, just like these natural teeth are abfracted from clenching their teeth, and the person either didn't have a night guard or quit wearing their night guard. And because the veneers are bonded to the teeth so well, that restoration flexes and fractures just like tooth structure. It's abfraction in a restored tooth. So they must have a night guard, and they should wear it anytime they're sleeping. Even if they take a nap, they should wear that night guard. To prove it to a patient, have them take their finger and bite on their bicuspid teeth and say, bite down as hard as you can. And they bite, and as hard, you say, what percentage of your bite do you think that is? Biting as hard as you can stand it. And it'll be about 10%. And say, imagine 10 times that, because that's how hard you're clenching when you clench your teeth at night if you're bruxing your teeth. So if you don't have a night guard, you are going to break something, either a tooth or a restoration. Remember, a patient can fracture anything that's tooth colored. That's why I'm a fan of gold crowns on second molar teeth if they're not displayed when the patient smiles or talks. Because you can't break a gold crown, but you can fracture a tooth colored restoration, even a zirconia crown. And the further back in the mouth you go, the more pressure there is on the restoration in the tooth. And so you can fracture anything tooth colored. So if a patient wants a tooth colored restoration on a second molar tooth, I have them sign off saying, I understand that this restoration is under a lot of pressure since it's on the back teeth and it can fracture, and Dr. Cutbirth does not stand behind the restoration. Replacing topical, blowing that into the gingival tissue. Learn how to give a painless injection. Painless and how to really anesthetize the tooth. Deep restoration or endodontics, you must give an intracellular injection. But learn how to give a painless and profound local anesthesia, and I've got videos on how to do that. This is the 30 gauge needle. Before I start, I see every morning, just about, I see a patient from 8 in the morning until 1 or 2 in the afternoon. So I have an outline of where we should be by certain times. So you can see in this case, I'm doing crowns on teeth number 3, 4, and 14, 6 to 12 veneers. Then we'll make the provisionals, take an occlusal registration record of the teeth that have received crowns. Now, if you're veneering just the anterior teeth, there's no space between the maxillary anterior teeth and the mandibular anterior teeth. So I won't place occlusal registration material, the blue mousse, between the teeth that are coupled, that touch together, and then seat the temps. So I'm thinking we'll be through around 12-ish. And this just is a guideline to keep us on track so we don't get deep into the morning and see we're not getting to the end of the case. I like to use a rubber dam for most things. It's a different rubber dam technique. You can watch this technique that I figured out years ago, that you've got one long line. You're not popping it between every tooth. See, this is one long cut. And that accomplishes 99% of the, see, it's all on these teeth. This accomplishes 99% of the traditional rubber dam method. But you don't have these strips in between every tooth, because if you're prepping them for crowns or veneers, you're probably going to cut the strips anyway. And this keeps the 99% of the water out of the mouth, any pieces of old filling or old crown, doesn't bounce around in the patient's mouth. You don't have to worry about aspiration. It keeps their tongue out of the way, the lips out of the way, the cheek out of the way. So it's easier on the assistant to aspirate. It just makes life a whole lot better for me and for the patient. You'll see I'm first prepping the first molar for a crown because it had a large interproximal filling crack on the tooth. It wasn't sensitive. Now, what if a tooth had been hypersensitive? If it's hypersensitive preoperatively, I'm going to perform endodontics on that tooth 99% of the time, because the last thing you want is for a tooth to be hypersensitive once you place the restoration on the tooth. You don't want to have to do endodontics through a crown if you don't have to, because it compromises the longevity of the crown. So this is a 330 carbide burr, and I use that as a depth cut guide. Then this is a occlusal reduction burr, and I don't have to wonder about how much occlusal surface to remove, because I have the depth cuts on the teeth, and I just prep to the bottom of the depth cut. This is a coarse football diamond. I use this because it cuts pretty quickly, and you can do the general part of the preparation with that coarse football diamond. Then I'm coming back with the mosquito diamond and just breaking the contact between the tooth being prepared and the adjacent tooth. Try not to touch the adjacent tooth if it's not being prepared for a crown. You can see the decay in here. So this is a flame-shaped fine diamond. I'm trying not to go subgingivally interproximally if I can help it. This is a coarse barrel diamond, just barely subgingival on the facial. There's no reason to go subgingival most of the time on the palatal. Then this is a fine small chamfer diamond for the margin. So anytime you've got dentin exposed on the facial, you don't want to prep deeply into that dentin unless you're performing endodontics on a tooth, because you can make a tooth hypersensitive that was not hypersensitive preoperatively, and you don't want to do that. Like I said, you don't want to perform endodontics on a tooth through a crown if you don't have to. If you think it's going to need endodontics, you'd rather perform endodontics ahead of time, before the crown is placed. Rounding the facial interproximal line angles and the interproximal palatal line angle. So she's already done a significant part of the preparation with the abfraction. You're just kind of connecting the tooth to the abfraction. You're not prepping into the abfraction. You're just getting rid of the secondary dentin and smoothing it. Now this is a seating lug, I call it, on the bicuspid teeth on the facial aspect. Objective of this lug is, number one, it protects the occlusal margin of the veneer, and number two, you have a definitive seating stop. If you've only prepared the facial of the bicuspids and you're trying to seat the veneer, it'll swim and you won't have a definitive seat. If you've got this lug cut with a small round burr, then it has a definitive seat, because I'm not breaking the contact between the bicuspid and the cuspid. I'm only breaking the contact between the from cuspid to cuspid. Mesial of the right cuspid, mesial of the left cuspid, and then in between the other anterior teeth. And I talk about why in my video on wrapping. See, so we've broken the contacts here. This veneer, this is the lug on the bicuspid. This preparation goes to the interproximal contact, and then this preparation is only to the contact. It doesn't break the contact between the bicuspid and the cuspid. We're going to break the contacts from mesial of cuspid to mesial of the other cuspid. Now we're going to prep the other side. So you'll remember this bicuspid had a large interproximal composite, so we're going to place a crown on the bicuspid. I'm cutting interproximally with the 330 carbide burr, not touching the adjacent tooth, and then I'll cut my depth cuts into the bicuspid with the 330. This is 2 millimeters, the cutting part of the tooth, and so that's exactly the depth I want for the occlusal reduction. Some people say reduce a millimeter and a half. I like to reduce 2 millimeters so the technician has plenty of room for the occlusal aspect of the restoration. We're also placing a crown on the first molar. So the first molar and the bicuspid are both receiving crowns. Doing my depth cuts so I don't have to think about how deep to prepare the tooth occlusally. I've got the depth cuts to guide me. It's just an occlusal reduction burr. Then I'm coming back with the coarse football diamond, and be very conscious of the dentin exposure. You don't want to prep in very much at all in that area. I'm just going to roughen it because she's pretty much done the tooth preparation in that gingival 1/4 with the abfraction. So you don't want to make the tooth hypersensitive. If those teeth were hypersensitive before I was preparing them for crowns or even veneers, the patient and I would discuss doing endodontics on the teeth prior to preparation, because the thing you don't want is a hypersensitive tooth after the restorations are placed, especially if they had hypersensitivity prior to tooth preparation and the hypersensitivity got worse after crown placement. So ice test them. You can watch my videos on how to test teeth with ice to see if they're hypersensitive. But usually the patient will tell you that they have trouble drinking anything or eating anything that's real cold. And if they do, endodontics on those teeth may be a part of the treatment plan. There are many reasons to do endodontics on teeth. You don't want to be cavalier about it, but you don't want teeth to be hypersensitive to the point the patient can't eat on the teeth, or every time they eat hot and cold they get a zing. People want to be able to use their teeth and eat pretty much whatever they want to. You can see some decay on the mesial of that molar. So I'm using this coarse football diamond to refine the occlusal aspect of the preparation. Then I'm coming back with the coarse barrel diamond to continue the refinement of the preparation. You can see how the patient has pretty much placed the margin on the facial of the restoration through abfraction. And so you don't have to prep that very much at all. You may roughen it just a little bit, but you don't want to prep into the tooth or you can create hypersensitivity. So this is just a little stain here. Just refining the margin with this fine chamfer diamond. So I'm not prepping much into the tooth right here at all on the facial 1/4, because the patient has pretty much placed the margin through abfraction. Now what's going to happen if she doesn't wear a night guard? She's going to abfract that area of the crown. She's going to blow the enamel off the side of the crown right there. And if you practice long enough, you've seen plenty of this with old restorations in people that clench their teeth and don't wear a night guard. I've said many times, my wife and I have had night guards all the time I've been a dentist. Our two daughters received night guards when they were 16 and had quit growing. So a night guard to me is like brakes on a car. I think it doesn't hurt anybody if it's properly made, and it helps people not destroy their teeth over time if they're teeth grinders and bruxers while they're sleeping. And it protects the restorations. Checking the occlusal reduction, rounding the occlusal facial line angles and the occlusal interproximal and palatal line angles. All right, now I'm prepping the anterior teeth for veneers. I like this burr. You want to cut straight between the interproximal contacts. And when you cut the cut between the central incisors, I like to tip the patient up and look at them sitting up square to me, so I'm sure I cut in line with a line perpendicular to the pupillary line. Means right, see, I've sat her up in the chair, and here's a line between the pupillary line. So I want this cut to be perpendicular to that line, which is right down the center of the face. The cuts between the laterals and the cuspids and the laterals and the centrals, it's not as critical. I mean, they don't have to be perpendicular to anything, but you want that line, the cut between the centrals, to be perpendicular to a line drawn between the pupillary line. So I'm going to round the facial interproximal line angles. So these teeth are about ideal. the average central is 11 millimeters. So these are 11 millimeters. So you know that the teeth are about the ideal length as they present. So I'm going to reduce the incisal 1.5 millimeters or 2 to make room for the restoration. I'm going to sit them up, and I was showing the line between the pupils, and I'm going to reduce the incisal edges of the centrals and the laterals and the cuspids approximately 1.5 millimeters. The incisal reduction for veneers ideally is about 1.5 millimeters or 2. Now what if these teeth were worn short? Say they were 6 or 7 millimeters, and when the patient licks their lips and lets their lip hang, you always want some tooth display. So if there was no tooth display when the patient let their lips hang and they had a flat lip, then you're not going to reduce really any tooth structure on the incisal. You're only going to roughen the incisal edge because you want to lengthen those teeth so that when the patient licks their lip and lets their lip hang like that, there's some tooth display with the final restoration. I hope that makes sense. If the teeth were too short preoperatively so that there was no tooth display when the patient licked their lips and went like that, there should always be some tooth display. If there was no tooth display, then you're going to create tooth display with the final restorations, and you're going to tell the patient in the provisionals, because you're going to wax up the wax up model to the ideal length, and the provisionals will be the ideal length. So you'll tell the patient to read aloud in front of a mirror for about 15 minutes a day, and it'll take them 36 hours to get used to the new length. And when they say F, S, V, church, and swish, those sounds will feel different with the incisal edges of those longer teeth. F and V are made by the incisal edge of the anterior teeth, maxillary anterior teeth, touching the vermilion border of the lower lip. F and V. F at the end of the sound, V at the beginning of the sound. Church and swish sounds are made with air passing between the incisal edges of the maxillary and mandibular anterior teeth. So those sounds will be a little bit different, but they'll adapt to them very quickly. Think about a kid that's lost their upper anterior teeth in the mixed dentition phase, and they can talk perfectly after a short period of time because they adapt to it. So tell the patient to read aloud in front of a mirror when they receive the provisional restorations. And before I send it to the lab, I always have them come back to the office in 3 or 4 days and let me check them. And they'll say, just like you said, it took about 36 hours and now I'm used to it. If it wasn't, if they weren't, I've never had them not get used to it. But you want to do any adjusting on the provisionals before you send the case to the lab, because remember, you're going to send the lab a model of the provisionals, and you're saying to the laboratory technician, this is a good length. The length of the provisionals is a good length for the final restorations. I've tested it in the office and this is a good length. So in this case, since the teeth are the ideal length, I'm reducing the incisal edge 1.5 millimeters or 2 from cuspid to cuspid. Now remember, with the incisal preparation, you want the incisal palatal line angle to be 90 degrees. You don't want to taco it onto the palatal surface. Then I'm going to reduce the facial about 0.5 millimeter. This is a coarse barrel diamond, but when you're doing your incisal reduction, be sure you tip the patient up so their face is on the same plane as your face, and you don't try to do that with the patient laid back in the chair, or it may be crooked. The incisal plane may be crooked. So I cut my depth cuts of 0.5 millimeter, and now I'm connecting them. Now the margin is not going to be, usually on my preps, is not going to be more than about 0.3 of a millimeter deep. The reason for that is the enamel in the gingival 1/4 of the tooth is only about 3/10 of a millimeter. I'd like to keep the preparation in enamel. The enamel in the body of the tooth is thicker. It may be 2 or 3 millimeters, but in the gingival 1/4 of the tooth, the enamel's only about 3/10 of a millimeter thick, 3 to 4. So I want to keep the prep in enamel. Composite bonds more strong, or composite bonds better to enamel than it does to dentin. So long term, the restoration is more secure if you can keep the preps in enamel. So you don't want a real aggressive prep for a veneer if the teeth are not dark. Now with dark teeth, you may have to reduce a millimeter on the facial. But if they're not dark, a 1/2 millimeter is just fine. The reason you reduce a millimeter with dark teeth, you want the technician to have enough room to block out the dark shade of the tooth. I'm just connecting my depth cuts. Now if you had a tooth that was facial verted, you're going to cut it back, and it wasn't dramatic. In other words, you didn't have to do orthodontics. You could correct it with the veneers. You're going to cut it back into the arch alignment before the veneer preparation. So you're going to cut it back so that it's in the proper arch alignment. Then you're going to reduce the facial of that tooth a 1/2 millimeter. So I'm always looking at the preps from the incisal vantage point with a large occlusal mirror, just to be sure the arch alignment is ideal. In a case like this, all the preps are in enamel. Now if there's an abfracted area, this is an interesting point. If there was an abfracted area or there was interproximal decay, I'm not going to fill the abfracted area probably with composite at the tooth preparation appointment. I'm also not going to fill the interproximal decay, or remove the interproximal decay and fill it with composite at the prep appointment. Why? If I place composite in that abfracted area or in the interproximal decay area, my provisionals are going to stick to that part, that composite, and it's going to be hard to get the provisional off. And when I do, I'll have to re-prep that part of the tooth because some of the primer adhesive will be stuck to that composite. So I'm going to restore that part at the veneer seating appointment because I'm placing composite on the veneer, in the veneers anyway. So I'm not going to restore any abfracted area or any interproximal decay until I'm seating the veneer. And what I would do is I would prep the tooth that requires direct composite restoration. I would flow the veneer luting composite into the veneers, and I'd also place some, after I'd etched and primer adhesive, in the direct composite areas. And as I seat the veneer, I would be restoring the abfracted area and the interproximal decay area. I'm just rounding these areas, and you can do the marginal prep either with a flame-shaped diamond or with a fine chamfer diamond. You can see the lug I cut in the bicuspid for seating, and that's on the facial. It's really not on the occlusal. And then the cuspid veneer, if there's a crown on the bicuspid, and I've prepped the bicuspid for a crown, then the cuspid veneer on the distal is going to be prepped to about the interproximal contact area. It's going to be prepped just facial to the interproximal contact area if there's not a crown on the bicuspid. In other words, you're not going to break the contact, but since the contact is broken for the crown on the bicuspid, then the interproximal margin of the cuspid is going to go a little bit deeper, further into the interproximal area. A lot of water, flame-shaped diamond, and small chamfer diamond. Then you're going to round the facial incisal line angles and the facial interproximal line angles. Remember, the incisal palatal line angle is going to be 90 degrees. You're not going to taco the incisal palatal line angle onto the palatal surface. The incisal palatal line angle is going to be 90 degrees, but all the other line angles, the facial interproximal, the facial incisal, are going to be rounded. So I'm going to be looking at this with an occlusal mirror as I prep the teeth to be sure everything will draw and that each tooth will draw. The veneer will draw on the tooth. Just refining the margins. So how deep are the margins in the sulcus? Remember, you never want to prep into the junctional epithelium. That's the tissue at the bottom of the sulcus, the attached gingiva. You never want to prep into that. You always want the margin to be in the sulcus. So I like to prep into the sulcus no more than 1 millimeter on the facial, maybe 0.5 millimeter to 1 millimeter, but not invading the biologic width. Do not prep into the junctional epithelium or you'll have inflamed, red, bleeding gingiva and gum recession once you place the veneers. Interproximally, I want to just barely be subgingival, maybe 0.5 millimeter or less. Remember, she's got some abfraction here, so she's pretty much done her marginal preparation with the abfraction. See, that's just barely subgingival. This is the occlusal mirror. I'm just looking at the preps to be sure everything draws. And then I'm refining the incisal edges of the anterior teeth with the patient sitting up, looking at them from the front. Then you want to round these incisal interproximal line angles. The only line angles that aren't rounded, remember, are the incisal palatal line angles. All the other line angles are rounded, and the interproximal palatal line angles are not rounded either. So the interproximal palatal and the incisal palatal line angles are not rounded. They're 90 degrees. Crowns on the we've got crowns on the molar, bicuspid veneers. See the lug, the seating lug, and it also protects the occlusal margin on the bicuspid. Then we've got crowns on the bicuspid and the first molar. Now we're going to fabricate provisionals from the wax-up model. This polyvinyl siloxane matrix is fabricated on the wax-up model. I won't go into the dimensions of the waxed-up model, but you can watch that video on how to wax up models for provisional restorations. You want to make the wax-up a little thicker than the presenting patient's teeth, because if you don't, if the provisional material is only 0.5 millimeter, it's like working with wet toilet paper. This makes the provisional material thicker so you can work with it. See, this is thicker. So when you fabricate the matrix on the waxed up model and then you place the matrix on the prepped teeth, the provisional material is going to be thicker and it's easier to work with. So you're going to wet the teeth. You want them sopping wet, and when you place the bisacrylate in the matrix, you want to rub the tip of the gun on the incisal portion of the matrix. Then these teeth are soppy wet, and I'm squirting this bisacrylate interproximally. Mark the midline so you don't get lost, and you want to be sure that the polyvinyl siloxane matrix also covers a significant portion of the palate. So when you push it to place, you can put your finger on the palate. You don't want to put your finger on the prepped teeth because you removed about 1.5 millimeters of tooth structure in this case, and it'll push too far, and you'll push past the provisional material. There won't be any thickness on the incisal. So as you remove it, squirt some water underneath there, it lubricates it, lets it pop out. I like a two-sided diamond disc for a lot of the provisional restoration trimming. Now I'm going to cut the provisional into 3 parts. Anytime I've got 10 teeth in a provisional veneer restoration, I'll usually cut it into 3 parts, and it's easier to seat those 3 parts than seat the whole thing at one time, especially if they're all veneers. If you've prepped 10 veneers on maxillary anterior teeth and you try to seat them at one time, the veneers on the bicuspid teeth will flare out like a starched shirt. So you want to cut between, normally I cut between the cuspids and the lateral incisors and seat 3, 4, 3. That's what I'm doing here, is cutting between the cuspids and the lateral incisors. This is a custom tray. You always want to use a custom tray with polyether and polyvinyl siloxane. If you don't, you'll get blibs and voids. I like polyether because it's hydrophilic. It likes water. So you can dampen the teeth, then you can either squirt it on the prep teeth, or you can, many times I'll just place the impression material with the wash on top of the body material. So while that sets, I'm refining the provisionals. So my assistant's holding the impression material in place, and I'm just refining the bisacrylate provisionals. Bisacrylate was a great invention because it doesn't heat and it doesn't distort. Up that, you can see how accurate that is. Then I'm going to rinse it real well with warm water and take a second impression with reversible hydrocolloid. It's very, very accurate. I always take 2 impressions. Now, I love scanned impressions if there are no subgingival margins. If there's subgingival margins, especially if you've got 10 preps like this, it's very difficult. I find it very difficult to capture the margin with a scanned impression. Some people say they can blow the air on the teeth and capture it with the scanned impression. I find it easier, and my technician finds it easier. I use 3 different technicians for different things, and all 3 of them prefer a conventional impression if you have subgingival margins. So scanned impressions, if it's for a dental sleep apnea snoring device or a night guard or a partial that doesn't, the margins are not subgingival, but if there's subgingival margins for veneers or crowns, I always use a conventional polyether with custom tray and or reversible hydrocolloid impression. See how deadly accurate these are. I take 2 just in case there was something on an impression that I didn't see that wasn't ideal. It's just nice to have that backup, kind of like having 2 parachutes. You may never use the second one, but it's sure nice to have it if you ever needed it. It'd be terrible to have to call the patient to come back in, be re-anesthetized, and take another impression, especially if you're doing this many teeth. But even if you're preparing 1 tooth or 2, I don't want to ever have to make that call and ask them to come back in for another impression. You should take a face bow. The face bow mounting orients the maxillary model on the articulator the same way the maxillary teeth are oriented to the skull and the mouth. So you get the dimensions right. The cant of the teeth is correct. So this bar should be parallel to the pupillary line. The bite plane can be whatever the teeth are, but the bar should be parallel to the pupillary line. And this lets the technician mount the case on the articulator so that it's seated the same way the teeth are oriented in the patient's mouth. I also send this photograph to the technician so that the technician can confirm the face bone mounting is correct, because this incisal plane in relation to the pupillary line should be the same way the model is oriented to the tabletop when it's mounted on the articulator with the face bow. This also goes to the technician. Take a shade. Now in this case we're using the ideal shade, and I want a natural light shade. It's an OM1. We're matching the mandibular veneers. I'll send this shade with it, shade tab with it. So you've got it in 3 pieces. Just checking the occlusion. You want to cut up the interproximal area so you don't strangulate the papilla. Be sure you've got some spaces in here in the interproximal so you don't strangulate that papilla. I'm going to take a bite registration record between the teeth that have been prepared for crowns. Now you can also take an occlusal registration record between the mandibular anterior teeth that have been prepared for veneers, because there's about 1.5 millimeters or 2 of clearance between the mandibular anterior teeth and the palatal surface of the maxillary anterior teeth when the patient bites together. When you're prepping maxillary anterior teeth for veneers, though, these teeth couple with the mandibular anterior teeth, so you don't want to put occlusal registration material between teeth that are coupled. You only want to put it between teeth that have been adjusted occlusally so that there's space between the prepared teeth and the opposing teeth. So this is just adhesive, Scotch Bond adhesive, placed on the teeth that are being veneered on the tooth side of the provisional restoration. So you dry it, dry the teeth, place these. You're going to blow the excess adhesive off the veneer onto the 2x2, off the provisional veneer onto the 2x2. Then I'm going to place Olympia cement in the crowns. I've got Vaseline around the teeth that are receiving the provisional crowns, and then again adhesive on the teeth receiving the veneer provisionals. You're going to blow the excess adhesive onto the 2x2. So crown and bridge provisional cement, and then adhesive on the veneer provisional restorations, and blow that off. Then I'm going to place flowable composite between the 3 sections. Cure that. So I'm curing the adhesive that's luting the veneer provisionals, and I'm curing the flowable composite that's luting the 3 sections of provisionals together. You don't want to wait too long to remove the provisional crown and bridge cement. If you do, it's harder to get off. You want to remove it when it is initially set. Don't wait till it sets completely. This is set just a little bit too long, and it's harder to remove. Check the occlusion.
Open. Lie down. Lie down.
I'm going to take a record for a night guard. It'll be a maxillary centric relation occlusion night guards, and I'm going to take this record, then we're going to fabricate the shell of the night guard before the patient comes in for the final restorations, so that we can seat, reline and seat the night guard at the time we seat the maxillary anterior restorations. These are provisionals. The patient leaves the office. I'm going to take an impression of the provisional restorations on the teeth along with photographs of the provisionals and send that to the technician and say, this is good. These links are good. Use artistic license, but basically these provisionals are a good length. It doesn't have anything to do with shade, it's just the length of the teeth. So these are the final. This is where we're going to end up. We're going to place these in the next episode on the maxillary anterior teeth and bicuspids. So that's dentistrymasterclasses.com. These techniques work, and they work every time. Hello, this is the final episode in a very interesting aesthetic case. We're veneering and crowning the maxillary anterior and mandibular anterior teeth and bicuspids. So in this final episode, I'm seating the final maxillary veneers and crowns. This before and after. This is where we're going to end up after this episode. So you can see we've got veneers on the 6 maxillary and mandibular anterior teeth. These are lithium disilicate or EMAX. We've got crowns on the maxillary molar teeth, and I believe this is a crown, and this bicuspid is a veneer. So this is the patient's upper left side. It looks like the right, but it's taken in a mirror. So we've got crowns on the molar teeth on the left side, the molar and the bicuspid tooth on the right side. The reason that the bicuspid has a crown and not a veneer is because it had a large interproximal composite filling. And then we've got veneers on the maxillary anterior teeth. Mandibular teeth, we've got crowns on this first molar, and I always crown the mandibular bicuspid teeth. These have crowns, then veneers on the mandibular anterior teeth. This is the patient presents after we've prepared the maxillary anterior teeth and bicuspids and molars for crowns and veneers. So these are provisionals that have been on her teeth for about 3 weeks. So we've already restored the mandibular teeth. So these are the provisional veneers and crowns on the teeth. It's easier to keep the provisionals on, and we have less trouble with patient breakage if you have crowns on 1 or 2 of the most posterior teeth in this arch, because they're all connected. So if you've got crowns on the molar teeth or bicuspid teeth because they needed a crown, either they had a large composite restoration or interproximal, or it was a molar tooth, it's easier for the patient not to break the veneers. If you've got 10 maxillary anterior and bicuspid veneers, chances are pretty good the patient is going to break the veneers on the bicuspid teeth at least once. They're going to bite something and fracture those off. So many times if it's just a bicuspid veneer provisional, we won't even replace it. We'll tell them if it's not an aesthetic issue, just don't worry about it. And if you do replace it, you'll replace just that single veneer. And I've got a video on how to place a single provisional veneer. Profound. Somebody asked about how to give us an infraorbital injection. You'd anesthetize it and you'd put your finger right here on the infraorbital foramen and just go right under your finger. First, just give the painless injection with the sit-nest plane and then follow it with lidocaine 1 to 100%. Watch that video on painless and profound maxillary and mandibular local anesthesia. This can build your practice. If you can give an injection that's painless and you know how to really anesthetize teeth, which these videos will show you how, you can build a practice. Most dentists I find just don't take the time to make local anesthesia comfortable, and they don't really know how to make it how to administer profound local anesthesia. It's a technique. It's a learned technique. So these are the restoration. You can see veneers on cuspid to first bicuspid, crowns on the molar, and that bicuspid. So this is the patient's left. It's taken in a mirror. Crown, 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 veneers. This is the solid model. Watch that video on how to never have to adjust interproximal contacts. And you do that by fabricating the restoration on a die model, but when you're perfecting the interproximal contacts, do that on a solid model, and you cut the tissue away, but if you perfect them on the solid model, see, this is the solid model. Luis is taking them off the die and putting them on the solid model just to verify the interproximal contacts. So this is the die model, and that was the solid model that the restorations were on. I want the technician to give me that little piece of paper that says the lithium disilicate has been treated before it comes to my office. I trust the technician and know they're going to do it, but I want to read it, that they've done it, so I don't even have to think about it. When you're removing the provisionals, you cut between each of the veneer provisionals with this mosquito diamond. Cut all the way through, then put a 2x2 in the mouth and just torque them with an elevator, and they'll pop right off. Remember, you've used adhesive only. You haven't used primer, and you haven't etched the teeth. If you use just adhesive, the provisionals will pop right off. Now there's going to be gingival irritation because all the provisionals are connected. Now these are crowns cemented with provisional crown and bridge cement. You know there's going to be some bleeding because they haven't been able to floss their teeth because the provisionals are connected. So I'm first going to polish the teeth with pumice and water in a prophy cup. I'm not worried about bleeding here. I'm going to rinse that. Then I'll place a 2x2 in the mouth and wipe them with isopropyl alcohol. Just want to clean up any plaque or little bits of adhesive that may still be on the teeth. I want to give them a good scrub. You put the 2x2 in the mouth just to keep the alcohol out of the mouth and rinse it. Now notice this is ice cold water in a plastic bottle with a large tip. You don't want to use your aspirating syringe here. That if you do, your air water syringe, if you do, you'll irritate the gums and make it bleed more. So you're going to use ice cold water in this water bottle and rinse it off. And we're going to try the veneers on the teeth. Now I end up redoing the 2 lateral incisors and the central, the 4 anterior teeth. The patient had to be in an event, so we went ahead and seated them. But something happened when the technician was waxing them up and the margins were shy. You know, I don't know what, we've really not had it happen before, but you see these margins are a little bit shy, so I ended up redoing the 4 veneers. The reason we placed everything was she had to be somewhere. That's always the one that's going to have something happen. And so we placed them for that event, and then we're going to see her again and replace those that were shy. And just isopropyl alcohol, cleaning out the lithium disilicate veneers and crowns. My technician didn't really know what happened because it had never happened before. Like I said, I'm not trying to make it look like everything is perfect. We have things happen in our office just like you do, and you just have to deal with it. Putting a little bit of Vaseline on the interproximal contacts. This just keeps the luting composite from being difficult to remove. So this is a little bit of bleeding there. So we're going to etch the teeth, and if there's any bleeding gingiva, we're going to be sure we put some etch right on that bleeding part for 45 seconds. I'm going to etch the teeth for 45 seconds to a minute. And I discovered by accident years ago that the 38% phosphoric acid is really good for hemostasis if you place it on the bleeding gingiva for about 45 seconds. Then I'm going to rinse it off with this cold water in the water bottle, and you can see everything that was bleeding has scabbed. You just don't want any flowing blood getting under the veneer. If you do, it'll make a dark spot. You'll have to redo the veneer. So I know I'm going to be redoing the 4 anterior veneers at a later date anyway. That's distressing when you have to have that happen, but every now and then It happens not very often though. I can't remember the last time that we've had to redo a veneer or crown. I'm blowing off the excess primer adhesive, and I blow into the incisal. So I want to be sure I remove anything that's flowing. Now I'm going to place primer adhesive on the teeth to be veneered. After they've been etched, just put it on there thickly. Then you're going to blow everything off. You're going to shelter the teeth to be crowned, and then you're going to blow off the part that wiggles. You don't want anything wiggling because you want to blow off any of the acetone that's the carrier for the primer adhesive. I'm going to squirt the Reliax luting composite into the veneers. You're going to seat them all at the same time. The reason you seat them all at the same time, they'll seat themselves perfectly. If you seat them individually and cure them, they might swim just a tiny little bit. Plus, you're going to have to remove the excess luting composite if you seat them individually. That'll make the gingival bleed. So for a million reasons, you want to seat them all at the same time. Now we've turned off the lights in the room. The only light is the operatory light, is the chair light, and it's pointed down at the patient's toes. So there's just a light glow because that ambient light will set up the luting composite. And you don't want to set it up until you've seated everything. You don't want anything setting. You don't want to use a light until everything is seated. Cotton tip applicators to seat them. I'm going to wipe this off on the palatal so I can view from the incisal surface and be sure everything is seated ideally. Then I'm squirting the Unisim crown and bridge cement into the crowns. I'm seating them at the same time also. Most of the time I seat the veneers and crowns that are adjacent all at the same time, and they seat each other. The contacts are perfect, and they go to place. Plus, you don't have to remove the excess luting composite or cement if you're seating them individually, because that's going to make the gums bleed, and you just have a mess, going through it all. Better to seat them all at the same time. Take your time. Like I said, the lights in the room are off. There's just a light glow from the operatory light. I'm flossing between these, pull it through on the palatal surface. Check everything with the cotton tip applicators. Good, then you're going to go 1001 on the facial and 1001 on the palatal. It's amazing how fast this light cures them. You don't want them to be, the luting composite to be completely set. You want it to be about like crunchy snow. You want it to peel off. You don't want it to wipe off. You can see how it's nice and firm just from that 1001, 1002. On the 1001 on the facial, and then 1001 on the palatal. So you want it to peel off. You don't want it to wipe off. If it wipes off, you're going to get some suck back in the microgap between the restoration and the tooth. And that can accumulate bacteria and cause irritated, red, bleeding gingival tissue. We still don't know exactly what happened to the margins on these 4 maxillary anterior restorations. Now this is the end of an amalgam carver, and then I'm going to cure each one for 60 seconds. The amalgam carver is good for removing any excess luting composite or primer adhesive on the facial of the veneers. Then we're going to cure each one 60 seconds on the facial and the palatal at the same time. You cannot overcure a veneer. You can undercure it. So I want to be sure that they're cured completely. This is a large fine chamfer diamond used to remove the overflow luting composite on the palatal surface of the teeth and just refine the margin. I want to be able to move and explore from the palatal of the tooth across the margin and not feel anything. This is a 12 fluted carbide burr, though these were just waxed a little short. That's why you'd like to use the same technician to do everything every time. I don't want to use a lab and have a myriad of technicians that are doing the work, because you've got to reinvent the wheel every time. I want to work out the system with one technician. We both know the system and we do it that way every time. So I don't know if he was having a bad day or somebody else waxed him up or exactly what happened, but they didn't wax them slightly subgingivally. Now this is the night guard. This is the shell of the night guard, and we took these records when the provisionals were placed on the teeth. We're going to reline it. I like to make them in the office so we can reline it when we seat the final restorations. So the shell is made of acrylic and the night guard is relined with bisacrylate. So wet the teeth, put a little Vaseline on them, let that reach initial set and come up with the back edge of a scaler and peel that off, and then slightly remove it and squirt water underneath there for lubrication, pop it off, trim it, do the fine occlusal adjustment and removal of excess luting composite with the fine chamfer diamond and the 12 fluted carbide burr. See, I want to be able to move that explorer from the tooth across the margin and not feel anything. Check the occlusion. You can watch my video on occlusal concepts. It goes through everything you need to know about occlusion. Occlusion is so important. Open. Open. Then you're going to polish with this gray shofu rubber wheel. Polish from the veneer to the tooth. We're going to redo these veneers right here. To my knowledge, we've not had that happen before, so I'm showing you real life. And check the patient in the upright sitting position, because the mandible moves forward about 1/2 millimeter when the patient's in the upright feeding position. So always check that. Be sure that the envelope of function is correct. Check the night guard. Just want the anterior teeth to contact. That takes 90% of the pressure off the muscles of mastication in the system. You can watch the video on how to make a night guard and why do you want to make it this way.
Is that better?
Check the eccentric movements.
Squeeze real hard. Move your teeth together, right, left, come back. Good.
So this is the final restoration. So we replaced those 4, which we did that just like we prepped them the first time. And this was the final result. And so we replaced these 4 veneers, corrected those margins. So we've got You see, this is super gingival right here because this is not in the aesthetic zone. There's no reason to go subgingival if it's not in the aesthetic zone. That's dentistrymasterclasses.com. These techniques work, and they work every time.